All right, this is Clostridium difficile, dentistry's overlooked threat, and this is August 30th, 2024. If you're watching this at a later date, you are watching the recording. I'm Dr. KRoling. I'm the Chief Education Officer here. I'm a public health dentist in Phoenix, Scottsdale area. I was the chief for the Office of Oral Health for Maricopa County's Health Department a while back, and I am a survivor of Clostridium difficile. To receive CE credit, you'll see in your handout, so exact copy of my presentation, the link to the quiz as well. I will be announcing a passcode at the end. You will need that passcode to complete the quiz. It is to verify your attendance. So be sure you write it down. I'll be speaking from 12 to 1:30 today. This is an hour and a half long. And there's my conflict of interest and financial disclosure. This course does not receive any sponsorship today. I do want to make you aware that Dr. Tom Palmer, who is the American Dental Association's co-author for the antibiotic guidelines for prophylaxis and odontogenic and therapeutic uses, is offering a course on our website November 8th. And you can access that by tapping on the banner at the top of the screen. So he's offering also a manual that he's authored, as well as his own office forms. I highly recommend the course. It is 4 hours long. And I think after you complete this course today, you might revisit. It'll also be available on demand, and we'll let you all know when that is available. All right. So I am a survivor of Clostridium difficile. And before I talk about my own story, I am going to give you a little bit of background about C. difficile. And again, for those of you that just joined us, be sure that you have the handouts. Take a peek at the chat area. You should see those. We've got a large class today too, so be sure you ask me questions. I'll try to get the answer for you if I don't have it readily available for you today. So Clostridium difficile, what do we need to know? We've got the learning objectives today. I'm going to review pathogenesis, clinical features, current trends and virulence, and prevalence of C. difficile infection. We'll identify populations that are at increased risk for developing this infection. We will describe ways that C. difficile bacteria can be transmitted, and then apply key principles and develop a specific strategy for infection control and prevention of C. difficile infection within the dental practice. This is going to include administrative controls, environmental cleaning, and antimicrobial stewardship. And I think some of the information that you received today may shock and surprise you, and that is why I'm here. Because when I trained at UCSF, and I remember the pharmacology lecture actually, and the mention of C. difficile. And the mention was basically, here's what you need to know for the boards, but that patients that developed C. difficile were carriers, that they were prescribed an antibiotic. We disrupted the quote gut flora, that's what we called it then, allowing a niche for these C. difficile spores to take over and produce toxins and make the patient sick. And at that time, it was thought that patients developed C. difficile around the time they were taking antibiotics or shortly afterwards. And if they developed bloody, watery diarrhea, for gosh sakes, make sure that they call their physician and probably get tested for C. difficile. And back at that time, the antibiotic of choice was either metronidazole or hospitalized with IV vancomycin. That's changed quite a bit because of antimicrobial resistance, which we'll talk about here. I don't know if you watch The Office. I'm sort of an office file, but this is one of my favorite quotes by Dwight Schrute. He says, "You only live once." False. You live every day. You only die once. And that's really my story today. So Clostridium difficile, again, was posed to me as a national board question that I'd need to know to answer, but that it was otherwise a fairly rare occurrence. And this was my training. I can't speak for everybody else's training. This goes back 30 years ago. But patients that got it were often the elderly or in nursing homes and so forth. But we did need to keep an eye out for our patients. And to my knowledge, I never had a patient that developed C. difficile. But I know now the reason is that we don't track the cases in outpatient settings. That's about to change as well. So let's talk about what C. difficile is. It is known really as Clostridium difficile. It was reclassified. Most of you will know it as Clostridium difficile or C. diff. It is a bacteria. It's an obligate anaerobe. It's gram-positive. It is a bacillus, so it's rod-shaped. It's spore-forming. It's toxin-producing in its vegetative form, and it's transmitted by the oral fecal route, but more often in healthcare settings through cross-contamination. Spores are found everywhere in the natural environment: the soil, seawater, river, air, in the desert dirt. It doesn't die. These spores can live for months to years. So they're very difficult to kill. And that's problematic in healthcare environments, including dental practices, because all healthcare environments are contaminated with C. difficile spores. And newsflash, including dental practices, which many of you may not be aware of. So C. difficile is found everywhere, including their shoes. And this was a study where researchers collected samples from public areas, healthcare settings, and shoe soles at locations across the US and 11 other countries. What did they find? They were comparing the rates of C. difficile between these settings. 26% of the samples from both sites, inside and outside healthcare, tested positive for toxigenic C. difficile strains. The shoe soles had the highest positivity rates. 45% of worldwide samples tested positive for C. diff, even though it's usually thought of as a hospital-associated infection. Those data are trending, right? That's changing. Hospitals are getting this more and more under control. They have outbreaks, certainly, but we have to be really concerned about are the outpatient settings. And we'll talk about that today, called community-associated infections. And dental practices are considered part of that. So the researchers included shoe soles to learn more about their potential role in environmental transmission, and wheelchair wheels as well, because they come into contact with the ground. And to help prevent the spread of infection, the authors concluded that simply washing your hands and taking off your shoes in your home could drastically help to reduce your risk. And in healthcare settings, certainly washing your hands effectively and frequently, and never wearing your work shoes home. I just wouldn't advise it. All right, so there are two phases of C. difficile infection. There's the vegetative form, and the vegetative form is associated with producing the toxins A and B, which lead to the colitis, what you remember as pseudomembranous colitis. And then the spore form, as I mentioned earlier, the spore is released, and it is a way for the bacteria to form a cocoon, if you will, and exist in environments that it normally wouldn't. It's anaerobic, so it can exist out in the air as a spore in tremendous heat here in the desert, in your dryer, etc. Very difficult to kill. So again, the vegetative form is associated with the symptoms. It is anaerobic. It can live on moist surfaces for up to 6 hours, and then it's going to die, all right? But it does produce toxins A and B. And the vegetative form is susceptible to the gastric acids of your stomach. So if you ingest a vegetative form and you're healthy, chances are your stomach acid is going to take care of it, which is one of the reasons why you have stomach acid. Antimicrobial soap and alcohol-based hand sanitizer will kill the vegetative form when used correctly. But it's the spore forms, the spores today that form, and why we should all be concerned. Because these C. difficile spores can survive on surfaces for months to years, and also any other inanimate object, doorknobs, ATM machines, that sort of thing. Resistant to gastric acid. So you'll see the transmission here currently, but when we swallow a spore or spores, it will just go right through the stomach acids. No issue, no problem whatsoever. In fact, it loves acid. And by the time the bile salts eject some bile, or the gallbladder ejects bile salts, those bile salts will also help with the germination of those spores into the vegetative form. Now, antibacterial soaps and alcohol-based hand sanitizers will not kill spores. So what is your solution when you wash your hands? The best way is under running water with soap and water. Many of the hospitals know that by using alcohol-based hand sanitizer in their environment, it will increase compliance for hand hygiene. But they also know that it is a risk for C. difficile because you will not kill the spores. You'll just move them around. So if you're washing your hands under running water, at least you have some degree or availability to just flush those spores away. So hospitals are rethinking that. And these spores, given the right environment, the stomach acids, the bile salts, will quickly transform or germinate into the vegetative state. So let's take a look at the diagram here of how this transmission of infection occurs. So we come into contact with the spores somewhere. And again, the spores are everywhere, but they're in greater numbers than healthcare practices. And once we ingest those spores, they make their way from the esophagus into the stomach, where they're subjected to the gastric acids, right? Hydrochloric acid. No problem for the spores. They pass through, they reach the small intestine, and bile salt exposure occurs. And this is what causes the germination of these C. difficile spores into the vegetative cells. Those vegetative cells continue to multiply and divide where they reach the large intestine or the colon. And now colonization occurs. They're producing toxins and making the patient or yourself very sick. So colonization resistance is part of our immune system. It's a specialized defense system. When we talk about our immune system, we're usually talking about our circulatory system, right? But the colon is there for a reason, because we have this community of bacteria that is there to protect us. And that's very simplistic. But these bacteria and also viruses, fungi, slime mold, amoeba, archaic amoeba, et cetera, these communities are very complex. They're communities and subclades and subclades, and they each have various physiological actions. Some actually produce antibiotics, for instance, right? So when we disrupt what is called colonization resistance, when we disrupt the gut microbiome, we're at risk for developing infection. All right, so we prescribe antibiotics to the patient. We disrupt colonization resistance. This can allow the C. difficile to proliferate and produce its toxins and cause symptoms. And when I talk about C. difficile, in this case, it's already germinated to the vegetative form. What is the difference between the vegetative state and the spores? So the vegetative state is the bacteria that you would normally see underneath the microscope, right? They're rod-shaped, anaerobic cells, bacteria. But when those cells are met with an environment where they normally wouldn't survive, they form spores, like cocoons. And they can live for months to years on your flooring, etc. And the spores, when we ingest them, can germinate to the vegetative form, producing the toxins and causing the colitis and making us very ill. So how does that disruption of the gut microbiome occur? Well, today we'll be talking about several different ways it occurs, but one way is when we prescribe antibiotics and the patient complies and takes them. All right, how does transmission of C. diff occur again? Disruption of colonization resistance. We disrupt it somehow. It could be through antibiotics, but you also have patients we'll talk about that are at risk, patients that have been being treated for cancer, patients that take proton pump inhibitors, etc. In combination with disrupting their gut microbiome, they come upon spore contamination and they ingest spore contamination in a contaminated environment. And oftentimes it's a healthcare environment. So colonization resistance, disruption in the presence of a carrier, which is how I was trained to believe a patient got C. diff, only accounts for 0.4 to 15% of the general population. I would be in that 15% because I've already had C. difficile. So there's a likelihood that I am still shedding spores. A high likelihood that I am, right? But they're not making me sick any longer, and we'll talk about that. But 0.4 to 15%. Antibiotic stewardship and effective infection control measures are required. Study indicated that 80% of those infected with community-associated C. difficile infections, and those are infections that occur outside of a hospital stay. Okay, some exposure to a healthcare outpatient setting due to spore contamination, right? Dental offices, physicians' offices, dialysis, etc. The spores are everywhere. They're nearly impossible to kill, and they can follow you home, putting your family members at risk as well. So let me show you a quick video. If you've taken some of my other courses, you may have seen this video, but it is definitely a good reminder. For some of you on phones, you may not hear this. You might have a conflict in your browser. If that's the case, the link is in your chat area or in your handout.
So let's talk about community C. diff, if we could, for a moment. What are the risk factors in the community, and how do they differ in the community versus the hospital-based population here? Dale, you want to start us on that?
Yeah, that's a really good question, because there's two factors that we need to have in order to get C. diff. One is antibiotic use, and the other is exposure to the spores. So the spores are ubiquitous. They're out in the environment. They even contaminate at a very low level some foods, meats, root vegetables, lettuce. And those are probably how patients in the community get exposed. They, on the other hand, when the CDC has looked at community-associated C. diff, they found that about 80% of these patients have had an exposure to healthcare as an outpatient. So it's doctor's office, dental office, and chronic dialysis units, ambulatory surgery. And this is where you have two risks. One is that somebody's going to give you an antibiotic, and those are called doctors. And,
we hope it's only doctors.
They put people at risk of C. diff. And the other exposure is that the healthcare environment is more contaminated with C. diff spores than is the environment outside of healthcare.
And I think it's worth noting, Paul is nodding his head. He does a lot of nodding. It's not just the people who are in the healthcare system. It's not just the people who got the antibiotics. They go home. They've got spores, and then their families are exposed. So it seems to me that that's part of the issue, isn't it?
And those spores can live for a significant period of time on many different surfaces, even when exposed to sunlight. And you'll see some data that says alcohol in certain products can kill the spores, but that it really has to be used properly, where the liquid sits on a surface for a significant period of time to have its effects. So the fact that the spores can be taken home with you on your lab coat and in your house and on surfaces for 6 months or a year or longer certainly put people at risk.
All right, so I'm thinking that may be news to a few of you, and it certainly was news to me when I became infected. So again, the study that they referred to here, 80% of those infected with community-associated C. difficile infection had some exposure to a healthcare outpatient setting, like a dental practice. And this is because of the spore contamination. And there are antimicrobials and there are disinfectants that you can use that are sporicidal and actually safer than what you're using right now in the tubs. All right, Clostridium difficile infection among healthcare workers. If you are a healthcare worker, and let's say you develop a sinus infection or a UTI and you're taking an antibiotic and you're working in an outpatient setting or a hospital, you are at risk, greater risk for developing C. difficile because you're coming into contact with this contamination all the time. This was a study with a conclusion here. Antibiotics were the strongest risk factor for developing C. difficile infection in healthcare workers, whether or not they had direct clinical exposure to the patients with the infection. It was by and large from coming across the contamination. What is your best defense? Anybody? Any answer for that? What's our best defense against C. difficile if we're working in a health practice or health environment? We'll talk about probiotics shortly. All right, bingo, Isabel got it. Wash the hands. Wash the hands and don't wear your shoes home, but wash your hands and infection control. But the number one on a personal basis for you is make sure you're washing your hands. Just be cognizant of that because you know, you're going to go eat, wash your hands, and you can wash your hands throughout the day. Definitely wash your hands before you see a patient and after you take your gloves off. But it is hand washing. How do I get handouts? You can go to the chat area. Let's repost those for you or check your email. Now, some of you may be in clinics that don't have sinks any longer. That's a problem, right? Because you're going to be using alcohol-based hand sanitizer. I would recommend finding a sink a couple times during the day. All right, here we have healthcare workers on antibiotics at risk for C. difficile. And this is a physician who speaks to healthcare workers in various facilities, letting them know that employee health should inform workers of infection risk. All right, stating, I think it would be a good idea for employee health to inform personnel about this risk if they are prescribed antibiotics. I do that routinely if I prescribe antibiotics to someone working in a healthcare setting. You should also let your patients know when you're prescribing an antibiotic that they need to stay away from the healthcare practices, which is problematic. If we're prescribing an antibiotic and we're inviting them back into our practice, which we'll talk about, that's problematic. Veterinarians know that as well. Veterinarians treat pets that get C. difficile, and they're subjected to quite a bit of C. difficile spore as well. All right, so again, if you are a healthcare worker and you're working in a healthcare environment, which I'm assuming most of you are at greater risk when you take an antibiotic. What can you do? You wash your hands and use good infection control. All right, any questions? I see we have a couple questions being typed here. So hand washing in healthcare practices are a huge issue. And I teach a course on effective hand hygiene. And I can tell you that hand washing is a cultural practice. If your team does not see the dentists or leadership washing their hands, they're probably not going to either. They're going to go in and they're going to reach for a couple of gloves and not wash their hands. The problem here is that it puts you at risk, it puts your patients at risk, and your patients are watching you as well. They want to see you wash your hands, at the very least, use alcohol or hand sanitizer. Any other questions? And again, for those of you that just joined us, be sure that you have the handouts by tapping on the orange rectangular message. You'll see a link there. So we're reposting. At the top of the screen is the next antibiotics update course that Dr. Palmier is presenting. I thought clindamycin use was the highest risk for getting C. difficile. It is. We'll be talking about that. So we said the carriers of C. diff represent 0.4 to 15% of the population. The percentage increases with risk factors, elderly, inpatient status, residency and long-term care facility, and others. Alcohol-based hand sanitizer does not kill C. difficile. So at some point during your day, if that's the only thing you have offered, I would make a recommendation that you use a sink somewhere in your practice and wash your hands at least a couple times. Definitely before you're eating. If you're only given alcohol-based hand sanitizer, that is a problem because the hospitals know and they're rethinking this. For nursing, they have patients laying in a bed, so they have to go to the bed and go over to the sink. And hospitals and the CDC know if you institute alcohol-based hand sanitizer, it will improve hand hygiene compliance. But they also know it doesn't address C. difficile, all right? C. difficile carriers can be asymptomatic. They can spread those germs to others who may develop a serious infection. And we said that those are infected can shed the C. diff spores for 5+ months or more and can continue to infect others who may develop a serious infection. So let's talk about the symptoms here. Mild symptoms, watery diarrhea 3 or more times a day, mild abdominal cramping and tenderness. Moderate to severe symptoms, watery diarrhea as often as 10 to 5 times or 15 times a day, abdominal cramping and pain that can be severe, rapid heart rate, tachycardia, dehydration, fever, nausea, increased white blood cell count, kidney failure, blood or pus in the stool. I had on the severe side here, moderate to severe. We'll be talking about my story in just a moment. Life-threatening complications, ileus or toxic megacolon. Ileus is a paralysis of the small bile. Toxic megacolon occurs when these patients that have C. difficile, in the majority of the cases, were advised wrongfully to take an antidiarrheal. And the antidiarrheal will stop or slow down the motility of the GI tract, including the colon. And when that occurs and you have an infection that is producing toxins, what happens? The colon will swell up like a balloon and it can burst. And the patient usually doesn't survive the experience. So that is a medical emergency. And you'll see many deaths of patients who've had C. difficile and they've died because of toxic megacolon. And they've died quite often because they were told to take an antidiarrheal. I was one that was told to take an antidiarrheal, but I didn't listen to the doctors. All right, toxic megacolon here. We're looking on the left-hand side, the inside of the colon. This is pus forming here. This is what colitis looks like in a serious C. diff infection. Bleeding and pus. This is the spore. What you see in this radiographic image is the image of a toxic megacolon. The colon has swelled up to large size. And you can see where they've measured it here in diameter. It's about, I think, 10, I think they're using inches there. Maybe it's centimeters. I can't really tell, but about 10 centimeters or 10 inches, whatever it is, it's large. You'll see on the next photo here. This is someone's colon that was removed. This is a medical emergency. My thinking is this patient may not have survived that experience, but often caused by antidiarrheals. So you never want to tell your patients that develop diarrhea while they are on an antibiotic or develop diarrhea while they're on their antibiotic to take an antidiarrheal, because it can lead to this. And there are many legal cases out there where that's happened, or the dentist has made the recommendation to take an antidiarrheal. All right, who is affected? Anyone but the following populations are at greater risk. Anyone taking any antibiotic is at risk for C. diff. It's not just clindamycin, it's any antibiotic. It can be any dose and any duration. We know that just a single dose of clindamycin can cause C. difficile. We know that clindamycin drops for cataract surgery can cause C. difficile. And Cleocin, the skin gel for acne, some cases of C. diff, but it's any antibiotic. When I became infected, the gastroenterologist told me he was treating a 17-year-old dental patient, third molars removed, had been given a Z-Pak. I have another colleague who had a root canal. It failed, was on antibiotics for that, extraction, on more antibiotics, amoxicillin, C. diff, hospitalized, 22 years of age. So again, any antibiotic, anybody in this virtual room today, the next time you take an antibiotic has a risk for developing C. difficile. There's nobody immune to it. But there are definitely things that you can do to try to lower your risk. All right, anyone who is admitted to a hospital is at risk for C. difficile infection because of contamination. A nursing home resident, the same. Anyone over the age of 65. Female, we're not sure why female populations are at greater risk. Anyone who's immunocompromised, cancer patients, HIV patients, patients that are taking medications for rheumatoid arthritis, patients with inflammatory bowel diseases, Crohn's disease, etc., at greater risk, and anyone with a prior C. difficile infection. There is nobody here that can prescribe an antibiotic to a patient who's had C. diff and claim that their antibiotic is not going to cause them to get sick again. And we see this a lot, where the dentist who will prescribe an antibiotic and say, well, we're just going to prescribe amoxicillin this time. You're going to be okay. No, you have to have a conversation with the medical team. For myself, I've been told I can't take an antibiotic ever again unless I'm in a hospital or an infusion center with a monoclonal antibody running in the arm at the same time. So you have to ask your patients if they've had C. difficile in the past, and if they've ever developed diarrhea with antibiotics, which is a common side effect of antibiotics, right? However, they may tell you, oh, yeah, one time I did. Geez, what was the name? And they had to give me an antibiotic. I had to go get tested. That's probably C. diff, and your patient may not remember the name. All right, why do we need to care? Nearly 500,000 initial C. difficile cases every year. Nearly 30,000 die. 15% of those deaths occur within the first 30 days of initial infection. Recurrent C. difficile infection, 20 to 30% with the first recurrence, and it will go up to 90% surety by the fourth recurrence. I had 4 recurrent infections and 4 hospitalizations. Hospital costs to treat C. difficile infection annually, $5.9 billion. Up to 1/3 of people who get C. difficile infection are likely to get it again. After the first recurrence, 6 in 10 are likely to have another infection, and 8 in 10 with recurrent C. diff were hospitalized in 12 months and at least 3 separate times. So I was infected for I had 4 recurrent infections over 7 months. I was hospitalized 4 times and I failed 4 rounds of antibiotics. We know that C. difficile infection is increasing in both prevalence and severity. The majority, so 56% of reported cases in this study were associated with a hospital stay, right? Healthcare facility, HAI, is a hospital stay. The remaining cases, 44%, were considered community-associated infections. We, as dental practices, are considered community-associated. Our patients aren't staying overnight in our practices usually. This is outpatient settings. 44% of those cases. Of these, it was estimated that 65% of the community-associated Clostridium difficile infection occurred after the use of antibiotics. That leaves 35% of the patients that never took an antibiotic. What was going on there? Were they at greater risk? Were they immunocompromised, etc.? Now, in 2013, the CDC classified Clostridium difficile as an urgent threat, one of 4 top urgent threats with the greatest number of cases, the greatest number of deaths and second greatest number of cases. And it is not required to be nationally notifiable, although that is probably going to change here because there is a bill in the works by an organization called the Peggy Lillis Foundation that I'll talk to you about. The CDC said that it's a high consequence antibiotic resistant threat. It has the potential to become widespread and needs urgent attention for the identification of infections and minimization of transmission, which is why I'm here today, because I want to get the word out to all of you to understand what this infection really is and what I think we can all be doing together to be part of reducing the rate in outpatient settings. Patients with recent C. difficile infection present a significant risk for transmission of spores during their outpatient visits. So the outpatient setting may be an underappreciated source of community-associated C. diff infection cases, and that is a quote from that study. Oddly enough, when I became infected, and spoiler alert, the dental practice called me to see if I could come in and keep my cleaning appointment, my hygiene appointment, a day after I was discharged from the hospital because, I quote, "We don't need to give you antibiotics." Wrong answer. You don't want me in your dental practice. You don't want me in your dental practice while I'm being treated for an active C. difficile infection, right? Does the infection contaminate the lungs and spread through aerosol? No, the infection does not contaminate your lungs. However, it can be spread through aerosol. Most definitely. We have a slide on that, so I will talk to you about that. Good question. Yes, so please don't tell your patients, listen, we need to keep that hygiene schedule full, so just come on in anyways. We're going to have you come back to a contaminated environment while you're being treated and contaminate our environment even more. Not a good strategy. All right, dentists are estimated to prescribe 10% of outpatient antibiotics. So while we're not the sole source as a prescriber, we make a measurable contribution. It's in the millions, and we'll see that number. Among the antibiotics that are commonly prescribed by dentists, some carry a higher risk for C. difficile infection. You'll see a document in your course folder. It's a PDF, and it outlines the antibiotics according to risk. I want to warn you, though, you can't use that to make a determination solely on what you're going to prescribe your patient, because your patient A needs to have the antibiotic to begin with. If they don't need the antibiotic, you're not saving yourself by picking one that you think's a lower risk. So you have to understand how we should be prescribing antibiotics. The guidelines for odontogenic and therapeutic uses have changed. Hopefully you're following those. If you're not aware of those, we have the link in the handout. And Dr. Palmier, who's the co-author of those guidelines, is teaching the course November 8th, and that course is at the top of the screen in the red banner. All right. Those antibiotics associated with a greater risk of C. difficile infection. Clindamycin, 14% of the antibiotics prescribed, the cephalosporins, 5%, and the fluoroquinolones. Now, dentists are the #1 prescribers of clindamycin in the community setting outside of a hospital setting. And clindamycin was removed from the antibiotic prophylactic guidelines twice, for cardiac and for joint replacement. So many of you may not have got the message. For your patients that are pen allergic, if you are still prescribing clindamycin, you are not prescribing according to the guidelines. And why was it removed? Why did the ADA remove clindamycin? Because the number of dentists are getting sued because their patients are developing C. difficile infection. So again, if you're still prescribing clindamycin, and many infectious diseases experts will tell you just remove it from your formulary altogether. It really has no place. You have other antibiotics that you can use. Dr. Palmier will talk about the very few times you may want to risk prescribing clindamycin. Question, what antibiotic is recommended instead? It is not a one-size-fits-all. There's a decision-making tree. So it depends on your patient. There are different options. Azithromycin may be one, but azithromycin also carries a risk. So you have to, if you don't know what they are, you definitely want to go to the link that we have for you today, because there are different options. And again, if you have the ability to join Dr. Tom Palmier on November 8th, I highly recommend it. It's 4 hours. He goes through every case scenario, and then you can learn how to gain access to him later. He will help you as a coach in your setting. So if you come up across a case and you're not sure what to do and you don't feel confident, you're able to call him and he can help you. Right? So consider him your antibiotic steward. But if you don't know and you're just blindly prescribing without any real idea of why you're doing it, or if you're being pressured by a specialist to prescribe the antibiotic, which we're getting ahead of ourselves here, he's going to help you with that dialogue, right? If the specialist, the orthopedic surgeon, wants your patient to take clindamycin, have the orthopedic surgeon prescribe it. But for gosh sakes, don't have your hygienist call to, quote, get a medical clearance on pre-med and then dish it out from a bulk container in your practice, because the liability there is huge, not just for the dentist, but the dental hygienist as well. If you are going to dispense antibiotics from your practice, that patient needs to be fully informed about the adverse events by the prescriber, not your hygienist, not your front office person, the prescriber. The patient needs to know what C. difficile is. If you're prescribing or dispensing clindamycin, they need to be informed of what their risk is. They also need to be informed that they are being prescribed an antibiotic that is no longer recommended by the American Dental Association. So if they do have a specialist that is still insistent on clindamycin, there are things that you can do that you should be doing. And Dr. Palmier is going to coach you through that on November the 8th. He has forms that you can use as well. And he is also authored a reference manual that you will get as part of the course. And I'm not here to sell the course. I'm here to save lives today, because I know there are many of you out there that are not confident in prescribing anymore, that you are being pressured and your patients are getting C. diff. And you may not even be aware of it, and we'll talk about that. All right, so study finds 81% of dental antibiotic prescribing was not necessary, and these were 168,000 dental visits from 2011 to 2015. And it was a study published in JAMA. This, I think, was Dr. Katie Suda. According to the guidelines from the American Heart Association and the American Dental Association, fewer than 1/5 of those prescriptions were needed because the patient did not have a heart condition that placed them at the highest risk of an adverse outcome from infective endocarditis. Then the antibiotics were not required. The lead author of this study said that the results indicate that dentists, who are responsible for roughly 10% of all antibiotics prescribed here in the US, should be included in antibiotic stewardship efforts. And the most frequently prescribed antibiotic was amoxicillin, followed by clindamycin. This is significant because clindamycin carries the greatest risk for C. difficile, and dentists are the highest prescribers of clindamycin, even though clindamycin was removed from the guidelines, right? So there's a lot in play here. I think we as clinicians are pressured by the patient. The patient was told 15 years ago they needed to take antibiotics for the rest of their lives. They may not believe you. What do you do in that case? Again, if you can get time off on November 8th, or we'll have the course available on demand afterwards, Dr. Palmier is going to address that. What do you do in those cases? Dr. Suda, the chief investigator, primary investigator for this study, found that clindamycin was more likely to be unnecessarily prescribed compared to amoxicillin. And another study in 2017 in Minnesota found that 15% of patients diagnosed as having community-associated C. diff had been prescribed an antibiotic by a dentist. At least half of those prescriptions were for clindamycin. All right. Possible rationale here, according to Dr. Suda, is that all medical providers face some pressure from patients to prescribe antibiotics. Dentists are in a unique situation, a precarious situation, because you get pressured from your patient as well as other clinicians. Antibiotics for dental procedures linked to superbug infection. Antibiotics prescribed by dentists may contribute to antimicrobial resistance and the growing problem of Clostridium difficile, because nearly half the cases of C. difficile now are antibiotic resistant. I had an antibiotic resistant strain. It's scary when you have an illness or an infection and there is no cure. You're staring down the barrel of death. And that is not an exaggeration. What do you do? What do you do when you're sick for 7 months, you fail 4 rounds of antibiotics, and you've lost nearly 35 pounds? You're down to 92 pounds. You call your attorney and you get your affairs in order. That's what you do. I don't recommend that at all. So we have to do something as clinicians to be part of the solution here. It's a very serious threat. In this case, many of the antibiotics were likely unnecessary. And taking antibiotics can put patients at risk, as we know, for C. diff and other adverse events. And many of us aren't even familiar with the term antibiotic stewardship. In hospitals and other clinical settings, there is an oversight group that oversees the prescribing of antibiotics in that institution, usually run by clinical pharmacists and a team of infectious diseases experts and so forth. They're looking at the type of infection the patient has, and is the antibiotic the appropriate choice. But because we work quite often in siloed practices, we don't have that antibiotic stewardship. We don't have someone helping us oversee our antibiotic prescribing. We don't have that sort of luxury right? That's what Dr. Palmier will be offering. So he gives out his number, his email, and you have contact with him. And when you have a case that you're not sure of, you have an expert there who can guide you through that, right? Stewardship means to guard. In this case, we're guarding antibiotics because we're running out of antibiotics that are effective. What antibiotics for pre-med in patients allergic to penicillin? There are several different ones, so it depends on your patient. We have a link to the American Dental Association guidelines, the updated guidelines in the handout here. Azithromycin is one, but it's not an all size fits all. You have to take a look at your patient and determine, do they have anything in their health history that would preclude you from prescribing azithromycin to that patient. All right. In addition here, 1/3 of the patient's medical charts that developed C. difficile, and I'm reverting back to the study that we discussed, the Minnesota Department of Health, included no mention that the patient had been to a dental practice, had received antibiotics from a dentist. The problem here is that if your patient is not consented properly to understand what C. difficile is or any other adverse events, and they develop diarrhea up to 90 days after they're giving that antibiotic, they're not going to think to tell their clinician or the emergency department, oh, by the way, I was at the dentist 3 months ago. I was given clindamycin or I was given amoxicillin. Do you think it might be C. difficile? So it delays the diagnosis. The physicians don't know, and the patients don't know. And that's why it's really important that the patients receive the proper consent. So treating bacteria, this is very true because the pharmaceutical companies have got out of the business of developing new antibiotics. It's not profitable. And many of the antibiotics that are being developed are being done in much smaller labs and so forth. And that's what we're up against here. There just aren't any new antibiotics that are hitting the market, so to speak. And so we're running out of antibiotics. It's called the post-antibiotic age. There's a course that I present on antimicrobial resistance superbugs, and it's available on our website as well. An earlier survey conducted by Minnesota Department of Health found that 36% of dentists prescribed antibiotics in situations that were generally not recommended by the American Dental Association, and reported challenges to this, again, because they're being pressured by their patients, they're being pressured by the specialists. Dentists write more than 24.5 million prescriptions for antibiotics a year. All right, so there's the link for you. The American Dental Association no longer recommends the antibiotic clindamycin for dental prophylaxis or therapeutic use, really including cardiac or joint replacement indications because of the C. difficile warning and the number of dentists that are getting sued for this. This is the boxed warning for clindamycin. And note, your patients don't see this boxed warning. Although it states Clostridium difficile associated diarrhea has been reported with the use of nearly all antibacterial agents, including clindamycin. Treatment with antibacterial agents alters the normal flora of the colon, leading to overgrowth of C. difficile. Now, but patients can develop diarrhea from taking antibiotics, right? That's a normal event. However, they need to be alerted that if they do develop diarrhea while they're taking an antibiotic or up to 90 days afterwards, they should contact you. You should be part of the clinical team that cares for them. You are the prescriber. So they need to understand they can give you a call. What are you going to do? You're going to make a recommendation that they contact their primary care physician or the gastroenterologist. and be tested. They need to be ruled out for C. difficile. And we don't have a crystal ball. We can't say, well, you've only had diarrhea for a couple of days. It's probably nothing. Take some probiotics or an antidiarrheal, which has occurred, right? The only way you can rule it out is to be tested. Okay, a recent study in the UK suggested that a single dose of clindamycin may cause complications, including death from C. difficile infection. And of course, clindamycin can cause more frequent and severe reactions than other antibiotics for antibiotic prophylaxis. So it's no longer suggested. Up to 15% of community-associated C. diff infection may be attributable to antibiotics prescribed for a dental procedure. This is a document that I have for you in your course folder, and this is a comparison of different antibiotics and the risk for community-associated C. difficile infection. And they break them down, and you'll see a document here or a diagram here. If you look at clindamycin, the adjusted odds ratio averages at 25.39. If you look at doxycycline, where is it here? Doxycycline carries the lowest. No, I don't see it here. There we go, 0.96. Right. Now, of course, antibiotics, depending on what the situation is, the infection that we're trying to treat, etc., will need a specific type of antibiotic. But this just tells you how dangerous clindamycin can be. Your patients are at much greater risk for developing a C. difficile infection. I never in a million years would have thought I would have developed a C. difficile infection, and we'll talk about that. And that link is there, and you have that document in your handout. All right, antibiotic-resistant C. diff infections in the US, nearly half the cases are now antibiotic resistant. For those of you that were trained, back in the days of dinosaurs like me, to believe that metronidazole takes care of this or oral vanco, nothing can be further from the truth. Metronidazole is still prescribed because it's cheap, but it's not as effective anymore. It's used a lot in nursing homes where they're trying to cut costs. Honestly, if I knew someone that got C. diff tomorrow, I'd tell them very first thing you want to do is take fidaxomicin. The oral vancomycin is starting to show more antibiotic resistance as well. I was on oral vanco for 3 rounds before they put me on fidaxomicin, which didn't do anything. Fidaxomicin difficile is the #1 go-to antibiotic now for C. difficile. It's much more specific for the bacteria itself. But by the time you get to the 4th or 5th infection, nothing's working anymore, especially if it's antibiotic resistant. All right, about a third of those deaths are due to antibiotic resistant infections. So we said C. difficile is highly contagious. It's difficult to kill. We can become infected with direct contact with patient care or infected person, indirect contact. So it could be in a healthcare setting or a community setting, and we pass it along to someone else. Contaminated surfaces. The only disinfectants that are approved to kill C. difficile spores are on EPA List K. And what are some of those? Again, you have to look up the product itself. You can't just go to Amazon and buy any old disinfectant. You have to make sure that the label is on EPA List K. Right. The majority of dental disinfectants that we use now are quaternary ammonium compounds. They do not kill C. difficile spores. Right. What is on EPA List K? The hypochlorite products. Bleach products, hypochlorous acid in the correct concentration will kill C. difficile spores. I recommend hypochlorous acid. The way I found out about it was when I had C. difficile and I had to have a surgical procedure. They told me, look, you have to mitigate your home for C. difficile spores because we don't want you to reinfect yourself. We don't want you to infect your family members or your pets. So we had to hire a biohazard team that specializes in crime scenes and C. difficile mitigation. Believe it or not, they had to come into the home and our vehicles, and they used hypochlorous acid. And that's how I found out about it. But I was not aware that the wipes that we use in our dental practices are not sporicidal. They will not kill C. difficile spores. If you look at the container of your tubs, it will say it kills C. difficile. It's a little misleading because the wipes will kill C. difficile in its vegetative form, which is anaerobic. It's going to die in a few hours, right? It does not kill the spores. We're going to see that it actually can lead to more cross-contamination of C. difficile. Quaternary ammonium compounds are toxic materials. And you'll see a couple of documents in the course folder that we have for you. One is on quaternary ammonium compounds. It was a publication last summer in a peer-reviewed journal. And the other is Dr. Rella Christensen's comments on the wipes as well. She doesn't believe in them for various reasons. Dr. Palmier, who teaches the course November 8th, he's now a believer in hypochlorous acid. His team uses hypochlorous acid in their dental practice as well, right? So again, we prescribe antibiotics, we disrupt colonization, and we invite our patients back into a potentially contaminated environment, and we're putting our patients at risk. So the EPA List K is there for you. And by the way, hypochlorous acid is a much safer disinfectant to use. Your body produces hypochlorous acid. It's used in wound management, etc. It's many of you may have used it in foggers in the beginning of the pandemic. Question here from Angela. My daughter had a serious C. diff case 3 years ago. After another of your classes, I heard of hypochlorous acid. We found wipes and gallon on Amazon. Is it reputable? I can't comment if it's reputable because I don't know what brand it is. The only way you're going to know, Angela, is look at the label and find out if it's on EPA List K. All right. If it's not on EPA List K, it's not a sufficient concentration to kill C. diff. The brand that I recommend, that Dr. Palmier recommends, and we have no financial affiliation with them whatsoever, is EarthSafe, EvaClean. And those are NADCC tablets, and you use them in a sprayer and with wipes, and we'll show you that in a minute. But, or bleach. So Clorox makes actual healthcare bleach, not the regular Clorox wipes. Those are quaternary ammonium compounds, but the medical grade bleach are the wipes. Now, the problem in your dental practices is you can't use bleach on all surfaces, right? You can't use it on your front counter, your granite, your upholstery. The beauty about hypochlorous acid is you can use it on all surfaces. At that concentration, you might get a little residual on your counters. Just take a damp wipe with the hypochlorous acid and just wipe it off. You only need 4-minute contact time. And again, it is safer, and you can actually, it's much more cost effective than what you're using now. You're shipping dry goods, you're not shipping water. Any other questions? Let's see what we have here. You're welcome. Yep, you definitely have to go into Amazon, find out if it kills C. diff spores. They're required to state that, and they're required to state the contact time and the concentration. Some of them will say that they kill C. diff spores, and you find out the contact time is 20 minutes because the concentration is so low. The other thing you want to be advised with is that the pH should be very close to neutral because you will corrode your surfaces in the dental practice. All right, so this was a study that showed environmental contamination in outpatient settings, also found in the provider's work area. Also, so again, another reason to make sure that you are doing your part for infection control, because it's traveling with your shoes. Dumiati et al. Reported that 69% of patients with community-associated CDI had received care at an outpatient physician office in the 12 weeks prior to their diagnosis. 83% had received outpatient care when dental offices and emergency department visits were included. So again, what surface disinfectant do you use in your dental practice? If it's this and it's quaternary ammonium compound, it is not going to be on list K, and it will not kill C. difficile spores. We have this document in your handout. Quaternary ammonium compounds, a chemical class of emerging concern. And the concern here is that despite their widespread use, most of these have not undergone rigorous regulatory assessment for the potential association with adverse human and ecological health effects. Evidence here of potential health effects: dermatitis, asthma, infertility, birth defects, and antimicrobial resistance. Disinfectant wipes transfer Clostridium difficile spores from contaminated surfaces to uncontaminated surfaces during the disinfection process. So you might actually be creating more cross-contamination. Yeah, there is a cavi white bleach on the list K. Unfortunately, using bleach on your plastics will cause them to turn yellow. On your metal surfaces, it can corrode them. And it's rough on your respiratory system. So hypochlorous acid is also used in grocery stores here. You go into the produce department, the misters come on. That's food grade hypochlorous acid. It smells like a very light bleach smell. This was a study where they looked at potential C. diff contamination in an outpatient setting. It was an infusion center. And the patients that were coming in for a particular monoclonal antibody that had active C. diff, it's called Zenplava, their operatories where those patients were being treated were compared to non-C. diff patients. Now, the non-C. diff patient operatories, they use the quats. They use the wipes that you all use. And the C. diff patients, they used the hypochlorous acid. What they found at the end of the day was that the patients, both patients brought C. diff spores in, but the patients that had C. diff, when they used hypochlorous acid, actually left less contamination behind after they did their terminal clean than the non-C. diff patients that they were using the quats. Can C. diff spores be aerosolized? We had somebody ask that question. Yes, they can. Flushing the toilet can aerosolize C. diff spores. If the spores are in your environment, like any other pathogen in your practice, contamination on the flooring or the countertops, yes, air currents can pick them up and transport them to other areas. There is a course that I present on effective hand hygiene. Hands are the #1 mode of transmission, and you're invited to take that course. And we did talk about the challenges of alcohol-based hand sanitizer. Warning about bulk soap dispensers. And if you took our infection control course last week, you heard me say this, that if you're using any dispenser that requires your hand to touch the pump, there can be contamination of this area. It can be either soap containers. It can also be alcohol-based hand sanitizer. What happens at that point is that biofilm grows in these containers, and now you're applying pathogens to your hands. And usually they are fecal pathogens. So if you're using this system, if you have the pump in the counter that you're pouring into, etc., that is problematic. So you want to go to a system that is hands-free. All right. And we give you the information there. Something that looks like that. And we have some links to videos here for you that you can learn more about that sort of contamination. This is hypochlorous acid, as we said. You can use it in an electrostatic sprayer. I'll show you that video very quickly here. So you might not be able to hear this, but you don't need to hear it, just see it. Boric acid in an electrostatic sprayer. That sprayer is 1 liter. You put 4 NADCC tablets in it. Now, she's using it more as a fogger. What you really want to do is stand about 1 to 2 feet away. Here's a gentleman using it in a healthcare setting. He is not wearing PPE. I know I'm going to hear from 6 people. He's not wearing a mask. He's wearing gloves. So some of you may have been using this as a fogger and walking around breathing it. It's okay. You'll be fine. But I recommend you wear PPE. This sprayer technology, you can use this on all surfaces. Your electronics, your countertops, your dental chairs, your upholstery during the lunch hour. You can go ahead and treat your reception area, the front desk. All right, blood pressure cuffs, dental lab, etc. All right, how long can it take for patient-prescribed antibiotics to become symptomatic? Up to 90 days, 1 to 3 months. In my case, it was 30 days after I took the antibiotic. Can we prevent C. difficile infection when antibiotics prescribed? Anyone can develop a C. diff infection. There is nobody out there who is at lower risk, right? There are definitely populations at greater risk. Probiotics are often recommended to patients in conjunction with antibiotics, but the research is hard to find. Probiotics are supplements, and the American Dental Association recommends that probiotics not be recommended to prevent C. diff because we don't have the science. The brand name of the sprayer is Protexus, and the name of the disinfectant is Earth Safe or Evaclean, either one of those companies. All right, so here's my story here. And you treat each operatory after each patient. So instead of using the wipes, you use the hypochlorous acid. You don't need to use the wipes, and you shouldn't combine the chemicals. All right, so my story. This is Dwight Schrute again. I'm ready to face any challenge that might be foolish enough to face me. So January 2022, I had a vertical root fracture of number 3, and I was referred to a periodontist. I wanted an implant, very good implantologist here. And he agreed that we'd need to get me out of that tooth and place socket graft, PRF, and have me back a few months later to place the implant. So I was prescribed clindamycin 150 milligrams 3 times daily, the day before the procedure and 5 days after. I had no infection. I had no periodontal disease. There were no post-operative complications. I returned 30 days later for a 1-month follow-up. And within 48 hours of that follow-up appointment, I developed severe gastrointestinal symptoms, frequent bloody diarrhea, fever, stomach cramps. I was worried I had colorectal cancer by the amount of blood. I called a gastroenterologist on my plan. They couldn't see me for 9 days because we were still in pandemic hell. So I was evaluated by urgent care, and I was misdiagnosed with irritable bowel syndrome. I was prescribed an anti-diarrheal. I even asked the physician, would this be C. difficile? I was treated with clindamycin, and he said, oh no, you would know it if it was C. difficile. Obviously, neither one of us knew it. The following day, though, my symptoms subsided, but then the following day after that, the symptoms came back with a vengeance, and I quickly became dehydrated. I had bloody, watery diarrhea about every 20 minutes with no control over my bowels whatsoever. The urgent care came to my home and they put an IV line in and said, you're dehydrated and we're going to give you some electrolytes and we're going to give you an antidiarrheal, this time Lamodal, and you need to take it because we're just going to be back out here again. But I had already read that the risk of C. diff could occur up to 90 days after that antibiotic. I was not confident in their diagnosis, so I did not take the antidiarrheal. I've been told today by a few of the folks that you saw there on Contagion that I wouldn't be here today if I took that antidiarrheal. I would have died. When I was evaluated the second time by urgent care, I had fever 100 degrees, sinus tachycardia, dehydrated, hypertension. They told me it was all from being dehydrated. And they said, you know, you need to get to the gastroenterologist, and that appointment was around about 3 or 4 days from them. So I get to the gastroenterology appointment, and he confirmed that it was a C. difficile infection, toxin B, through testing. In fact, he looked at my notes and he said, Kirsten, what do you think this is? I said, I'm really worried it's C. diff. And he said, it is C. diff. It is. We've got to get you tested. And this is what the test results look like. They do a stool sample, PCR positive for C. diff. The inflammatory marker here, the calprotectin, should have been below 49 mcgs per gram. I was at 753. I was very, very ill. And then, of course, the others, these are the tests that they look at. I had multiple recurrences. I did not respond, as I said, to the antibiotics. And my husband said, you need to do what you do best. You need to research and find someone to save your life. And I was really lucky. I teach a course on probiotics, and you knew about fecal transplant. I found a colorectal surgeon here in Scottsdale who was performing them. And he got me in right away. And within 24 hours of the fecal microbiome transplant, I was completely turned around. I want you to know that my bill no longer is at $52,000. It's at about $86,000 to treat C. difficile. One of my antibiotics was almost $6,000 deficit. It was not covered by my insurance company. The donor for the fecal transplant was through Oral Biome. And I was entered into a clinical trial to be able to have that procedure. And the criteria for that is pending death. My photo here is right before, on the left, right before I was diagnosed or symptomatic. And that's my 4th hospital admission in the middle. And that is me at the weight of about 92 pounds a day after the fecal transplant, and the first time I was really able to eat solid foods. So FMT is endorsed for recurrent C. diff, but not yet advised for IBS, IBD, and you do have to meet certain criteria, but the FDA has recently approved the first fecal microbiota product called Rayboda, and it can be used in office as an enema. I was in an endoscopy unit with full sedation. There's another called Voust, and these are capsules that patients can take, and they're also a live biotherapeutic to help with recurrent infections. So this is huge. These 2 medications weren't even available to me 2 years ago. Zinplava, as I mentioned earlier, is a monoclonal antibody. You go to an infusion center. It didn't work for me, unfortunately. We've got a C. diff explainer video here, and I want to play this quick video. This is Christina. This is from the Peggy Lillis nonprofit foundation, and she is going to tell her story.
My name is Christina. I'm from Columbia, Missouri. C. diff for me started in 2012 from the overuse of antibiotics as a preventative measure for a root canal. Within a week, I knew that things were very, very wrong and was quickly put in the hospital and diagnosed with C. diff, which I had never heard of before. I was about to be married, so I wanted to be planning my wedding during that time, but instead, the next 7 months, I was in and out of the hospital 6 times. I missed 7 months of work, and I was growing gravely ill and dying. I barely made it out of the hospital in time to attend my own wedding, and my honeymoon was instead spent in the geriatric ward, too weak to even stand. All the antibiotic treatments failed me, so I resorted to the FMT, which is the fecal transplant, and that ended up saving my life. Fast forward about 3 years, I had a 2-year-old little girl named Pearl. I was 9 months pregnant with our son, and my daughter became violently ill. And I never gave her antibiotics. So it was my horror when she was hospitalized and diagnosed with a C. diff infection. And I watched her endure the pain, the fear, the sickness, the isolation, and for a 2-year-old, that's very scary. I realized that, the body is a lot stronger than I've been giving it credit, and it's been 5 years and I have not needed any antibiotics. I've been able to fight on my own.
Okay, we've got just a couple minutes left here, so I will get through the rest of this. These are some comments that I found. Dental patients that were just completely unable to figure out what to do. This was a father, 36 years of old, got C. difficile, given clindamycin for a tooth extraction, and talking about losing 30 pounds, not being able to eat, and so forth. And others got amoxicillin for wisdom teeth removal. Should I quit taking it? And somebody said, did you have C. diff before? And they said, yeah, I had it 2 times last year. So they slipped through the cracks. So these are just interesting anecdotal stories from patients that I found online. What can we do to make an impact? Of course, professional development begins with dental school. Antibiotic stewardship. Be aware of the latest guidelines. Understand how we should be prescribing, right? Get rid of clindamycin. Infection prevention to mitigate for C. diff spores and advocate for C. difficile awareness. There are other technologies we have at our disposal that we might be able to use before we reach for broad spectrum antibiotics, and definitely ask our patients, have they had C. difficile in the past? These are some legal cases that Dr. Palmier sent me. There's a 35-year-old father prescribed clindamycin to quiet a non-vital tooth prior to endo, and then developed diarrhea. The dentist prescribed Lamodal to the patient. The patient died of megacolon, toxic megacolon. And the dentist's defense in that case was that his study club recommended that that was the regimen, but the jury did not go for it because the jury said, doctor, you prescribed outside of the guidelines. Here's evidence, ADA's evidence-based guidelines for antibiotic use. Dr. Palmier is one of the co-authors of this. And again, we'll put the link up there for you if you want to know more. There's some resources for you. Here's the evidence-based guidelines for prophylaxis and antibiotic stewardship. Here's the link to list K. Note that, again, this is an urgent threat. C. difficile has the second highest number of cases, the highest number of deaths, and it is not nationally notifiable. So we've talked the talk, we've got to walk the walk. I think all of us as clinicians know what we need to do. I think we get caught in the middle often with our prescribing and what the patients want. Resources here from our platform. This is the link to Dr. Palmier's course, and you can learn more. It will be available on demand as well, and it's 4 hours. You'll receive his authored manual and office forms that you can use, and it's much more than just what antibiotic you need to prescribe. It's how to have a conversation with the medical team, with your patients, and unusual situations that you're faced with where you may not feel confident in prescribing. And then you'll learn how to have access to him after the course so that he can help guide you with, or your clinic, with decisions in the future. We do have a cdifftoolkit.org. You can reach us for more news. We launched that last week. November is C. diff Awareness Month, which is why we're having the course November 8th. We support it every month.